So, good evening, Ramohan. Shiva, is Dr. Kairam there? Shiva, Dr. Kairam garu unnara?
లేరు సార్, ఇంకా రాలేదు. సార్ జాయిన్ అయ్యారు.
హలో సార్, ఎలా ఉన్నారండి?
Okay. I'm good. How are you? I was just inquiring about you.
సార్ గారు జాయిన్ అయ్యారంటే నాకు చాలా ఆనందంగా సంతోషంగా ఉందండి.
Yes.
బుద్ధరాజు గారు,
Hello, good evening, Kairam.
you are going to drive the train a bit today.
I thought there were a couple of speakers, right?
No, there are. There is Shravanti Tigavarapu, hematologist,
Okay.
and Dr. Guntupalli might also join us, but not necessarily in the very beginning.
Okay.
I sent her some...
So Dr. Guntupalli is a pulmonologist, right?
Yeah, she's pulmonary critical care.
Okay.
She
And what is Shravanti going to talk about?
hematologist.
So she's going to talk about hematological issues in COVID, or?
Yes, including
Okay.
anticoagulation,
Okay.
acute management, hematological issues.
Okay.
And I also sent her several of the questions that were raised in the last few days.
Okay.
Dr. Guntupalli just texted me. She will come on in the beginning and introduce Shravanti. They are from the same university.
Okay. So we have about 70 in the audience.
But it's not 8 yet. I don't know if I want to beat up on a dead horse anymore. My brother-in-law was finally discharged
All right, that's a good sign.
after 21 days of steroids with no oxygen.
Okay.
So we are all blowing in the wind, are we not?
Sure. I mean, that's happening a lot, but hopefully he'll get through okay. It's still probably less than 3 weeks that he got steroids, right? So hopefully he can get him off the steroids quickly.
He was given a 10-day taper. So I made my nephew very unhappy, saying, Mama, please don't fight with the doctors in Andhra Pradesh. I got to live with them.
Okay.
So I said, I'm going to turn them over to Buddharazu.
Andhra or Telangana? He's in Telangana, right?
Hyderabad.
Hyderabad, yeah.
I'm an old timer. I haven't recognized Telangana yet. Anyway,
So I just came across some news, both through our school as well as through NIH. So there was a recent publication in Science about a new antiviral drug that's been developed called, I think, Tempol, which apparently is showing a lot of promise in vitro studies, and they're looking at potentially starting phase 1-2 studies. So that's roaming around the ID circles today.
But by the time you get EUA, it will be 1 year.
I don't think COVID-19 is going any place in the next 1 or 2 years. I think we're probably talking about an endemic disease now.
What is the latest with the 2DG availability? Still on a trial basis?
I think so. It hasn't, maybe Dr. Sudhakar knows better. I don't think it's been included in the guidelines, ICMR guidelines. So there, I think basically the advice is to use it as part of a research protocol to designated institutions. So I don't know if Andhra Medical College is one of those institutions.
Dr. Sudhakar, are you involved in a 2DG trial at AMC?
They were
Yes,
involved in the early.
Yeah. Dr. Buddharaj, Dr. Kairam. We were involved in that trial earlier, and now that we had an extensive webinar the other day, in which they said that it will be made available in the first week of June, but it's not yet come. But the two in a limited stock. And the opinion that they got from the audience has been this: there need to be the more extensive studies to prove that it really works. So I spoke to the person and he said that he will come back to me, and he said that he would want Andhra Medical College KGH also to be part of an extensive study, maybe which runs in thousands of patients. So that's the update for now.
So I suppose we are months away from it.
I think so.
Okay, we have our speaker on the screen, and Dr. Guntupalli will introduce Dr. Thigavarapu. Dr. Guntupalli, go ahead, please. Good evening or good morning for them.
Yeah, good evening. Okay, Sravanti, I was just looking for you. It's my pleasure to introduce Sravanti Thigavarapu. She's an assistant professor in hematology oncology section, and she's mainly practices at Baylor St. Luke's Medical Center, where they have had many cases of COVID, maybe at least 1,500, a couple of thousand. Welcome, Sravanti.
Thank you, Dr. Guntupalli, and thank you, Dr. Ram, for involving me and giving me an opportunity to participate in this and share whatever our experience has been with COVID-19 here. And I wanted to kind of start off with, I thought I put together a few slides. I'm sure this is information which pretty much all of you already know. And maybe a lot of repetition and redundant. So I apologize, if this is something you already know, which I'm sure you do. So just thought we'll briefly summarize, because I know the main purpose of this webinar was to kind of go over, all the clotting issues and the anticoagulation, which we have been doing, which again has been rapidly changing over the last 1 year. So let me see if I'm able to share my screen.
Thank you.
Give me one quick second.
You have the green box at the bottom for share screen, right?
I do. I'm just trying to find my thing. Give me one quick second. Are you all able to see this?
Yes.
Yes,
Okay.
we can see.
So this is a brief, like a 10-minute thing, because I know this is pretty much what has been going for the last 1 year. But I thought I'll just kind of cover the most recent stuff in terms of the couple of trials which were published or in preprint. So again, I think the biggest issue is both intensivists and hematologists have battled over the last 1 year is with both macro thrombosis and micro thrombosis with COVID-19, in addition to all the respiratory issues which pulmonary critical care physicians have been dealing with. And as you all know, I think there is multiple clotting cascade abnormalities which happen with COVID-19. Some of these things which are grayed out, I hope you can see them, with increased tissue factor, which starts the whole procoagulant process. With increase in PT and decrease in platelets and TPA and increased degradation of fibrin and fibrin degradation products, which we measure as D-dimer, and then again endothelial dysfunction, which is one of the primary mechanisms for microthrombosis, especially in lungs and some of the other organs as well. So the evidence in support of thrombosis in COVID-19 has been with marked D-dimer elevation, which correlates with all the inflammatory markers, increase in fibrinogen levels, and slightly low to normal platelets. I think this is, I didn't put the PT and PTT, which are only mildly elevated, not markedly elevated, in contrast to the sepsis-associated DICs, though in later stages you may find marked elevation of PT and PTTs. And then the microthrombosis in the lungs with pulmonary vascular endothelialitis and pulmonary intravascular coagulopathy, and then the macrothrombosis, as you all know, with high reported rates of thrombotic complications, be it DVTs or PEs or other thrombosis. So the thrombosis risk has varied since the beginning of the pandemic. In ICU patients, it was about 15 to 30% initially, despite thromboprophylaxis, mostly pulmonary embolisms, but the most recent data suggest otherwise, lower rate, 3.5 to 7%. In the ward patients or the non-ICU patients, it's been about 3 to 7%. And the outpatients much lower at 1.8 cases per 1,000 tested, with incidence very similar to people who are negative for COVID. And then there is small increase in risk of acute ischemic stroke, which is about 1 to 1.4% in hospitalized patients. And this is in general covering the most major thrombosis risk. I might have overlooked or skipped some of the other minor thrombosis. So the current risk factors for VT in hospitalized COVID patients were ICU admission, of course, with severe illness and more inflammation, obesity, which is even an otherwise risk factor for venous thromboembolism, male gender, a high D-dimer. Again, I think this slide, by the time it was made sometime last year, I think we may have changed some of these cutoffs for D-dimers with more recent papers showing some numbers there in terms of D-dimers, with D-dimer greater than 2.025 from one of the Chinese papers, very suggestive of prognosis or suggestive of judgment for death. Again, different cutoffs have been have come out from different retrospective studies, including less than 1 to 1 to 3 and so on. And then active cancer receiving anti-cancer treatments. So I would divide clinical COVID-19 staging, and this is again taken from one of the papers, according to the ambulatory patient who is non-hospitalized, the outpatient COVID-19 positive patient, the hospitalized patients, the ICU patient, and post-discharge. So we have different anticoagulation guidelines, as you can see, which were put together. And again, this is across the nations globally. And as you can see, every society has slightly different recommendations. And I apologize if I've not put together either the Indian guidelines or some of the other guidelines. here. And as you can see, what we follow here is typically the American Society of Hematology, especially as a hematologist, though I know intensivists are looking at chest, which kind of run pretty parallel, I would say, not very different in terms of anticoagulation guidelines. Now, again, this may differ a little bit when I move on to next slide, where this says for severe COVID-19 patients, conventional low-dose thromboprophylaxis and moderate patients as well with conventional low-dose thromboprophylaxis. I'm sorry, was somebody trying to say something?
No. It's a disturbance from somebody's open mic. Please continue.
Okay. So as you all know, there is a high risk of VTE in critically ill patients, which is nothing new to you. If you look at some of the systemic analysis and meta-analysis, the non-ICU was about 5%, whereas ICU was around 31%. In the same way, there was a higher mortality in ICU patients who developed thrombosis or who were diagnosed with thrombosis than in patients without thrombosis. And so keeping this in mind, this was the most recent study, which is a multi-center randomized trial addressing some of these questions about what to do for these ICU or critically ill patients, or even otherwise not critically ill patients in terms of anticoagulation, given thrombosis is a major risk factor for worse outcomes. So this, as you all probably already know, is the ATAC, REMAP-CAP, and the Active-4A, which is a multi-center randomized controlled trial across different platforms where all these studies came together. And the primary question evaluating was with the hypothesis that in severe or critically ill COVID-19 patients, therapeutic anticoagulation or giving higher doses of anticoagulation would probably improve the outcomes. So that is one of the initial data which has come out, which is in preprint, still undergoing peer review. Again, it may change because the peer review has not yet happened. But from the interim or the non-peer review analysis, as you can see in the severe state, it was not significant. And in fact, the study met the futility rate of about 99.8%. And in the severe state, I'll go back and forth between these two slides. As you can see, they tried to measure patients who were given therapeutic anticoagulation versus prophylactic dose anticoagulation. And if you look at the curves here, they're pretty similar, showing that there was no difference. And the primary outcome in this study was a little bit different from what we typically measure in terms of thrombosis, something called organ support-free days, which means the number of days these people did not require any kind of support, especially with high-flow nasal cannula or mechanical or non-invasive ventilation methods. So this study showed that in severe or critically ill patients, therapeutic anticoagulation really did not make a difference, which again is very interesting because if you, if this was, again, contrary to what we have been hearing from, Bates when it started in New York, initially in Seattle and New York, where everybody was doing therapeutic anticoagulation in ICU and in fact, even in the ward patients. So surprisingly, it showed this. Again, this comes with its own caveats about how we put this into practice, given the question of why are these patients actually or fail to show a benefit. And some of the theories have been that maybe by the time these patients were starting therapeutic dose anticoagulation when they were severely ill, it really did not make a difference in terms of their outcome. Or maybe it's possible that because of all the pulmonary vascular inflammation they had, this could have probably contributed to some alveolar hemorrhage. So again, we don't know if this is going to be practiced from now on, but this is what it was in severe, severely ill or critically ill patients. Now, in terms of looking at moderately ill patients with a moderate state, as you can see, irrespective of the D dimer, again, this is not in preprint yet and yet to come out, but adopted from the slides of the author, it does show that it was superior. In fact, it benefited those patients. When these patients were started on therapeutic anticoagulation, preventing them from going to ICU. And in fact, if you look at the data, it showed like a 4.6% reduction or difference, almost close to 5% of these patients. You could probably prevent going them to ICUs. And again, in the moderate state, maybe it does make sense as to, you know, maybe if you try to act ahead of time and put these patients on therapeutic anticoagulation, maybe you can prevent things from worsening and improve the outcomes, or prevent them from having any kind of organ support. But the biggest issue is why the severe state is not showing benefit there. So moving on to the next important trial was the Inspiration trial, which again, I'm sure all of you almost know about this as well, is again looking at ICU patients where instead of the therapeutic dose, they looked at the intermediate dose, which is again based on weight. They used enoxaparin, which was either 1 mg per kg daily or 40 milligrams, which would vary again based on the weight and creatinine clearance. And as you can see, the intermediate dose, you know, in these in the critically ill patients or ICU patients, really did not add value, again indicating that prophylactic dose anticoagulation would be sufficient in these patients as well. Probably one of the last studies or more recent studies, which I thought I should cover, was about initiation of thromboprophylaxis. Again, this was an observational cohort, not a randomized control, unlike the prior studies. And when I say the prior study, the active 4A, which was a multi-center RCT, this was an observational cohort study where they looked at about 4,000 plus patients and found that, you know, initiating prophylaxis within 24 hours is what these people took, did have an absolute risk reduction of 4.4% with a relative risk reduction of 30-day mortality of as high as 34% over 30%, concluding that every patient should be initiated on some form of prophylactic anticoagulation, which you would otherwise do even in hospitalized patients who would fit the indication, but also as a treatment for COVID-19. So in the ASH COVID guidelines, which is what we all follow here, you know, again, if you can see, they have made changes based on the inspiration papers that, you know, prophylactic or intermediate intensity is sufficient. And again, waiting to make changes in with regards to therapeutic intensity over prophylactic intensity anticoagulations. So in summary, going back to the slide, which I put very initially about what would you do with an ambulatory patient, I have actually not put data because I know this was a Q&A session, but just briefly about ambulatory, again, there has not been enough data to support the use of routine thromboprophylaxis in these ambulatory or outpatient COVID-19 positive patients to prevent DVT or PEs. Unless they fit indications otherwise, or unless they were diagnosed with a PE or DVT or other kind of thrombosis. And in the hospitalized patient, you should consider starting prophylactic anticoagulation within 24 hours. And in the moderately ill, you should consider therapeutic anticoagulation based on the data, which is not yet printed out, but coming from a randomized controlled trial. And in the ICU critically ill patient, from the preprint data, not peer reviewed yet, prophylactic anticoagulation is what you should consider. Again, this need to be taken with some caveats, given we don't know how the practical application of some of, especially the severely ill prophylactic anticoagulation patients would be. And in the post-discharge, again, I've really not showed slides, but looking at some of the studies, including, you know, Extend and some of the other 3 or 4 studies where they compared either enoxaparin versus some of the DOACs, or placebo, the rate of post-discharge thrombosis was less than 1%, especially if they did not have any other risk factors. And therefore, they didn't think that there was a routine need for extended prophylaxis. And in some high-risk patients, they recommend doing Xarelto for from days 31 to 39 or so on, if you look at some of the NIH guidelines. And again, at the end, I would say that ultimately, all these anticoagulation recommendations sometimes are very institutional. This is a very important and a rapidly evolving topic. What I'm saying today may change in a couple of weeks. It has changed so much in the last 1 year since this pandemic started here about how we have been practicing. And I think every institution should probably, follow the guidelines which has been set for there, taking into consideration some strong data if it is available, especially from a randomized controlled trial.
Thank you very much for that summary. As I mentioned to you, over the last few days, we have come up with many, many questions. If I may, I want to ask the first question myself. Compared to if you look at the last 15 or 16 months, in 4-month, 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 4-month epochs, the macrothrombosis, does it seem to have declined? First 4 months, I heard a lot of that. More recently, not much.
I think so. I would say so. We were seeing a lot more. And again, it was really hard to discern because, or kind of really get the exact incidence, because we were trying to follow Seattle, follow New York, and start them on therapeutic anticoagulation ahead of time, in the ICU patients. We really did not do in the wards, though, as New York was doing, because I think Houston was hit third, or at least if you go in the US, in a major wave form. So definitely the incidence has declined, but it also could be due to declining numbers of COVID itself, and also probably to do with vaccination, though again, there is some vaccine-associated thrombosis, which is a completely different topic, but we have not seen a lot of that, very few of those. But yes, I would say so.
So maybe this is interesting to me. I could ask Mr. New York himself, Dr. Chilimuri, is there a decrease in macrothrombosis?
Yeah, there is. I think, as she said, we see a lot less cases. So we have seen it much fewer now. And I think that's because the disease is recognized early. We know when to admit patients now. And they started on steroids on day one. So we don't see macrothrombosis.
Dr. Mallampalli raised his hand.
Hi, Dr. Shravantia. It was a great presentation. Thank you so much for the literature review. I know there has been a lot of inconsistencies in the recommendations from different societies as well as different health systems, and across the US as well as across the world have different practices. Each study that you've been presenting has gotten a different findings, and then the final ASH guidelines I felt like it's a little different than what was found. So going back to the first slide you put, the Jimenez study, or the Jimenez, I think it's probably like just an incidental, like observational study, right?
Right.
And in that, even the ambulatory patients, if you can go back to that slide, even the ambulatory outpatient population had quite a high incidence of clots, VTE. So my question really is, why, if it is really the relative risk is that high, why is ASH not recommending outpatient anticoagulation? That's number one. I mean, that, So is there like a risk benefit ratio thing, or is it?
So, a couple of things I can think of is, I mean, one, I know there's an active 4B trial which is ongoing, which is trying to evaluate, outpatient starting of anticoagulation to reduce the, risk of thrombosis, which I think we'll have those results in September sometime is what I heard. So maybe it can shed more light and ASH may change recommendations. The other thing is, I don't know if, again, I don't know, depending on the cohort of patients who are enrolled, I don't know what the testing was. Maybe, by the time these patients were probably already moderately ill and not true ambulatory, where they already, or they had other risk factors, be it some of the hereditary conditions, or maybe they were obese, or some of the other autoimmune, whatever conditions which normally would predispose to VTEs. So I suspect, I don't know if you have a subset analysis looking into that, but I think it also could be to do with both testing, probably under identification of those as ambulatory rather than somewhere close to moderately hospitalized patients is what I would think. But I'm hoping once that active 4B comes out, maybe we'll have more, they'll probably make some changes to the ASH, guidelines in terms of ambulatory setup. But it would be interesting to know because, a lot of ambulatory patients are worried. I mean, we have huge obese and other risk population, especially in hem-onc, as you know, seeing a lot of patients who are, with underlying malignancies or heme malignancies. And it's always a concern when we don't put them on anticoagulation, even when they are pretty asymptomatic or mildly symptomatic. Thankfully, a lot of my patients did well. A couple of them really succumbed to it, and could not get through to it.
Yeah, I'm a full proponent of do no harm first. So definitely, again, it's not a good idea to just anticoagulate everybody outpatient. That's for sure. Yeah. A couple more before I go. So sure. The post-discharge, I think you told me that there is the Xarelto recommendation in certain the high-risk population. That is based on the which trial was there a trial?
So I have to I cannot remember. So this was, I think it was based on the modified VT risk, the scoring system.
Yes.
I cannot remember the author or quote the name. I apologize for that. But this was one of the things where they said you could consider in high-risk patients, where you would suspect that they're the higher risk for Xarelto, but it was based on that scoring system.
Right. Yeah, I think it is. I remember what you're saying. We discussed about it yesterday. There's a name for it, but yeah, I remember. Yeah. So high risk patients.
Right. I think and some of the a lot of trials. I think there was ADOPT trial. There was a Explain trial. I think there was some Megalian trial. All these were outpatient trials where they were testing different permutations and combinations. Xarelto, rivaroxaban versus placebo, or enoxaparin versus placebo, and so on. I think overall most trials actually though had some reduction in thrombotic incidence. I think the rate of thrombosis itself was less than 1%. So I think that's probably why I think this active 4B will help us, decide what we should do with these ambulatory patients. It definitely would be interesting to see what that shows.
Yes.
Okay, Dr. Buddharazu had his hand up.
If you don't mind, Dr. Aram, I have a couple more. Just one more question.
Okay.
Follow up. The new thing that I learned from your presentation is that the moderately ill patients, which are like maybe step down, maybe on the floor, not yet in the ICU, benefited from therapeutic anticoagulation. That is something new I learned.
That is the data. Again, this is not even in preprint, and I actually, these slides are courtesy of the actual authors who are part of this study, Dr. Zyron, and I may be saying the name completely wrong, Dr. Zyronek, and then Dr. Matthew Neal. They are the leaders of this this multi-center randomized trial, and I'm borrowing these slides from them. And again, we have to keep in mind that this is not even in preprint and or peer review, but this is what their data shows, that it was stopped, and there was like a ASH kind of update too, where it said, if you look at some of the ASH, American Society of Hematology, COVID-19 resources, in Jan 2021, they made a statement putting out that it showed superiority. And so irrespective of D-dimer, they're saying there was benefit, which actually does make sense. I'm a little confused about the severe one, though the only thing I can think is maybe it was too late by the time they started.
Okay.
Thank you.
Dr. Buddharaj.
Yeah, hi there. So I had the same question as Dr. Mailampalli. So early January, ASH came out with this results. But following that, in the middle of January, they actually said until the peer review is pending and detailed analysis pending, they still didn't recommend therapeutic doses for moderate disease. And I've been waiting for that interim analysis. I've never seen it. I'm not sure if it's out yet.
Like I said, these are some of the slides which I borrowed from author presentations, and that's why I was kind of repeatedly saying this has to be taken with a caveat. This is not published yet or not in preprint, and this may change because it's not peer reviewed. But that's what they saw, and you're right, Dr. Buddharaju. You're absolutely right.
Yeah, because I do hematology consult service at University of Nebraska, so I haven't made the change in those guidelines for our COVID patients.
Exactly, and I was about to say that we are still following. We have not made any changes. We are still doing prophylactic dose for for most of our patients, and if there is a clot, of course, therapeutic anticoagulation is warranted. So we have not made change, and that's why I was saying in the last that again it's very institutional, and I would not, and that's why I said you should consider, but I didn't say you should be doing.
Sure.
Yeah.
So the other comment I wanted to make was, I think Tom Ortel at NIH is running that NHLBI study using 2.5 milligrams of apixaban in ambulatory patients. I think that trial is a quadruple masked, recruiting about 5,000 patients. They use apixaban 2.5 randomized to a placebo-controlled randomized study. And I don't think that they're expecting results until August, September of that study. But that study is not only looking at VTE, but I think is also looking at post-COVID thrombotic events like strokes, if I remember right. And I think on the protocol, the study arm was going to receive 30 days, or the placebo, 30 days post-discharge. That will probably answer a lot of questions on prophylactic doses in ambulatory patients. But right now in India, the way I look at it, the moment somebody is diagnosed with COVID, everybody is getting a prescription of 2.5 milligrams BID of apixaban, which I'm discouraging right now.
Yeah. No, I think there are 3 or 4 studies. You're absolutely right. NIH, as you said, and there is Apollo study. That's also, I think I don't know if that's the same one, but I think I saw 3 or 4 with different dosages, again, between 2.55, and then there is one with the Xarelto running too. Definitely would be interesting. And I think I actually had a couple of family members, who were back in India who were given prescription for COVID, and this, for apixaban, and extended, anticoagulation, and they had the same question. And again, the data is not very clear. It's really hard, especially, when you really don't know if there's any underlying risk factors which made that decision, or was there a severe kind of COVID which made the decision. It's really hard to kind of, probably give firm advice on something like that.
Have you noticed higher incidence of antiphospholipid antibodies in COVID-19 patients at your institution?
That's a great question. At some point around October or something, we were obsessed with antiphospholipid, where this question came, and ICU was asking us, to check for antiphospholipid. And again, I think there is some, I think there was a paper which suggested there could be some higher incidence, but I don't think we ever made it routine practice. I personally, from the consults we have had in COVID patients, actually have not come across any positive antiphospholipid, but that is I'm limiting to our medical, our hospital experience. At least when I was on the consult service, we did not see a lot of that.
So there was a hue created after a guy by name Zhang, I think, published a letter which was not peer-reviewed, showing 3 cases of multi-system thrombosis in COVID-19 patients with positive antiphospholipid antibodies.
Yeah,
I think that's
exactly
how it started, but I don't think that data has been replicated anywhere. We certainly haven't seen.
Us neither. I think that's when the pressure was, on us for every consult to check it. I think we actually even did it in a few patients, but then after a week or a couple of weeks, we didn't think it was encouraging enough to continue that process. And I think by that time we thought we should wait for more data before we make it routine practice. And thankfully, we stopped doing it after that.
Thank you.
While staying on that topic, at the other end about when to discontinue, we have been generally hearing and telling people to stop discharge. But I want to ask you a specific question on a particular case. We have a regular participant who has been telling us about the course of the disease of her father-in-law in Andhra Pradesh over the last 10 days. Some of the regular participants know this case. Dr. Guntupalli, this is the young lady Neelima who's been talking about her father-in-law. As of now, this 63-year-old male, post-COVID day 14, oxygen saturations 95, 96 with 6 to 8 liters. They had received remdesivir, enoxaparin, solupret at admission. His comorbidities are diabetes mellitus, hypertension, multiple myeloma. Currently, he is only on oxygen therapy. Is there any current role for anticoagulants and post-discharge? She's already concerned from all the debates of the last few days. At the time of discharge, do I have to continue the anticoagulant?
So a couple of questions about his myeloma. What is it? I mean, is he getting treated? Is he in remission? Is he on maintenance? Or and the next question would be, was there, if I missed when you were saying, because I know there was some background noise, was there any venous thrombosis which was diagnosed apart from the prophylactic or whatever anticoagulation was being done for COVID-19?
Neelima, please speak up.
Yeah, he is actually a patient a month ago.
Your speaker is bad.
Just a second.
Disconnect, reconnect.
Okay, can you hear me now?
Yes.
Hello, can you hear me now?
Go ahead.
Yeah, so he had a relapse of multiple myeloma 1 month ago, and he was started on chemotherapy. Then after 2 weeks of the cycles of chemotherapy, he got infected with COVID-19. So that's the scenario right now. And he particularly doesn't have any risk factors for venous thromboembolism or any of that sort. He is just an uncontrolled hypertensive, diabetic, and multiple myeloma. That's it.
I see. And if I mean, is he, and there was no evidence of venous thrombo or any kind of thrombosis in admission?
No. Even at admission, his D-dimers were normal, excepting elevation of CRP around 70.
I see. And no clot he was diagnosed with of any kind. And no prior history is what I'm assuming as well. Is that right? Of any kind of thrombosis? No. Okay. Yeah, so again, as you know, I mean, any kind of active cancer on chemo, if you look at our slide, is kind of a risk factor. Again, it comes down to the same question about when do you stop anticoagulation in these patients. I mean, there is clarity on if you have a clot, the chest guidelines are saying that you would consider COVID-19 as a provoking factor and you would treat as a provoked clot for 3 months. If you don't have a clot, that's where all of us are stuck, what to do. I mean,
if he was my patient with myeloma, as I have I treat heme malignancies predominantly, not a thrombosis person, but if he was my patient with myeloma, I would, put him on anticoagulation at discharge, despite no evidence of data about it yet, just because of his underlying myeloma, which is active, you're saying is relapsed.
Yes.
And I don't know how mobile he is, if he's older, especially, and if he has other, factors where he's not moving around. So taking into consideration the general risk factors and then the myeloma, I personally would do that. Again, this is coming from me, not from any kind of evidence-based. Again, I think the recommendation has been to either stop if there is no evidence of clot, do it for 3 months, and some people have done it for 14 days.
Okay.
So yeah, I don't think we have very clear-cut guidelines, but I know Dr. Buddharaju is also here, and I would, if there is anything, what you would do different, I would be interested to know that.
Yeah, so unlike you, I do mostly benign hematology and thrombosis, and I treat very little in terms of hematologic malignancies. But yeah, myeloma itself being a procoagulant state, and frequently these patients have been or are on thalidomide or Revlimid or one of those procoagulant medications. I would probably do extended anticoagulation on these patients too.
Okay.
I think there's one trial which is looking at aspirin, which I forgot to mention post-discharge. But I think that is still pending as well, about aspirin for no prior risk factors, just at discharge prophylaxis. But I don't think we have any results from that yet, or at least not that I have seen.
Okay, thank you.
Staying with aspirin from the front end, there's a nice question. Is there any change in anticoagulant dose of starting protocol in cases where patient already on prophylactic medications like low-dose aspirin? Somebody who's taking low-dose aspirin already comes in. COVID anticoagulation question.
So that's a great question. I think from that trial which we saw where there was a 4% absolute reduction, I think everybody within 24 to 48 hours should be started on some kind of prophylactic anticoagulation. And I think the recommendation is for heparin for 2 or 3 reasons. There is, and I'll talk about the aspirin too after this. So heparin, as you all again know, nothing new to you. It's an antithrombotic, it's anti-inflammatory. It also prevents binding of the SARS-CoV-2 protein. For 3 or 4 reasons, it has become a popular choice. And also because it has less interactions with, all these other CYP3 inducers like DEX or tocilizumab and things like that. So I think, majority of studies have recommended using some form of heparin for, anticoagulation initially. So I would consider doing that. Would you consider low-dose aspirin? Maybe, because there is a trial arm in this active, which is looking at platelets as well, because they have been implicated in this thrombosis because of platelet fibrin, thrombosis and other thing in the microvasculature. So I don't know if that would look at all these antiplatelet agents. So if there is no bleeding risk, you could consider that. But if there's any bleeding risk, maybe you just want to do heparin. Now, since it's not a therapeutic heparin, a prophylactic dose heparin, the bleeding risk would be not high. So it may not hurt to continue both of them.
I see. Among the various anticoagulants, which one is preferable? I suppose it should be split into prophylactic versus therapeutic.
So again, heparin products, I think, have been predominantly the popular choice, because of interaction issues, as we discussed, because it's CYP3, and then again, DOACs, again, have their own issues, especially when you're using tocilizumab. And the other thing also is, for, and I think enoxaparin has probably been a more popular choice compared to heparin drips, and a couple of reasons. One is to avoid, less patient contact, and second thing was also a criticism from the active for a preprint study is, the unfractionated heparin was being used in these severely ill patients. And could the titration, because there's a lot of inflammation going on, were they able to maintain a therapeutic PTT, because of all the excess inflammation which is going on. So I think enoxaparin, I would say, is probably the choice, or at least what was used in majority of the studies and kind of being recommended too, or some kind of.
I mean, Sravanti, the chest recommendations that were published September 2020 also say that they prefer low molecular weight heparin or fondaparinux over unfractionated heparin for to reduce staph contact.
Right.
Absolutely.
That was the other thing, is reduced contact, which I forgot to mention. Right. And again, if you have HIT or any history of HIT, then fondaparinux, as you were saying, the only thing is fondaparinux is with a longer half-life, which we sometimes have to kind of deal with. As Dr. Budraju, it looks like you were about to add something to that.
No, I think across the board, most institutions in US prefer low molecular weight heparin. Yeah. It's no different at our place. We generally try to avoid DOACs. There was a question about monitoring anti-10A levels and things like that in DOACs. That's not recommended. We typically don't check coagulation parameters when somebody is on DOACs. The other question that I saw was a cluster of mesenteric thrombosis in Madhya Pradesh. I've heard of this. So I've seen 2 or 3 episodes of mesenteric thrombosis, but all 3 of them had GI manifestations of COVID-19. And so that might play a role. So it might be that in MP, there's a lot of patients, especially with increasing numbers, there's significant GI involvement with COVID-19. So I think Prem Kumar had asked that question. Have you seen a lot of mesenteric thrombosis?
Dr. Budraju, I was going to ask him to speak for himself. Dr. Prem Kumar, please go ahead. Prem, are you there?
Yeah.
Go ahead.
Yeah. Hi there. Actually, I have a lot of doubts. I have typed in the chat box, and the panel. If the panel kindly go through and answer them. I have a lot of questions. Actually, suppose a CAD patient is there. He's already on ecosprin and clopidogrel. Once he gets COVID and hospitalized, shall we stop ecosprin, clopidogrel, and start on Clexane? That means Lovenox.
Yeah, that's a very good question. I think we initially had a lot of confusion about what should we be doing. Again, I think a couple of things need to be maybe taken into consideration depending on was it a recent stent related Plavix that you cannot stop, or the clopidogrel, or was this stent a while away, and is there a possibility in that case you could do aspirin and heparin, or some form of Lovenox? That's kind of what that's kind of what at least we did, is we would see, could you do triple therapy? Maybe if the bleeding risk is not high and somebody cannot get off, and cardiologist says that this was a very recent MI or stent, then probably you could take a chance and see, especially if there is no prior history of bleeding or the bleeding risk is low. So again, I don't think there is a very clear-cut answer. We had few patients like that, and we have just tried to do aspirin, Lovenox, and maybe held the Plavix. In very few patients, we have tried to do triple therapy.
And after discharge, the same patient, can you put on ecosprin, clopidogrel, and Dox?
Again, this is similar to hematology consults when we get consulted for people who have even if COVID was not there, we always face this problem as hematologists. Be it a stroke patient who has both, or be it a MI patient, and then somewhere there is a venous thrombosis, and we are kind of always having a discussion about should you do the triple treatment or should you not? And again, we are always trying to look at the bleeding risk and see if we can do this. Again, in this case, it depends on whether if there was a thrombosis, right? If there was no thrombosis, there's probably no indication for DOAC. But if there was a thrombosis and you need some form of DOAC, then again, I think I would have to wait with the bleeding risk and check with cardiologist about that. That's what I would say. Again, I don't know what you have done with your institution, Dr. Budraju.
So typically there's a vascular indication for dual antiplatelet therapy. So usually that doesn't impact our choice for prophylactic doses of anticoagulation with low molecular weight heparin. The question only arises if there's a documented VTE or a PE. So if it's a vascular related indication for dual platelet antiplatelet agent, frequently what the cardiologist will tell us is I'm okay with just using one antiplatelet agent, preferably clopidogrel, for people who have stents, and then we would proceed with therapeutic doses of anticoagulation. So the mechanisms are different, especially with somebody who's had a lot of drug-eluting stents. We're very careful about not taking out the antiplatelet agent because of the prothrombotic nature of the disease. The question usually arises only when there's an indication for therapeutic anticoagulation.
Exactly.
So yeah, I would not take off the antiplatelet agents because somebody who's on dual antiplatelet therapy, I suspect is for vascular reasons, either for stroke prophylaxis or has drug-eluting stents.
And my final question is, vaccine-induced thrombotic thrombocytopenia, especially with, ChAdOx, this Oxford AstraZeneca vaccine, we are getting it. And they say it is some anti-PF4 or something. So how do we go about it? And is there any, things to predict in whom such things can happen?
Yeah. I think prediction is mostly, just having a history of getting the vaccine, right? So I think it's been shown with AstraZeneca, as you said rightly, and then some Johnson & Johnson, but not a lot. And again, I think the suspicion should be with, again, because this is somehow shown a predilection for unusual site thrombosis and thrombocytopenia. VIT, I think it's been a name given to this. And I think the hallmark has been thrombocytopenia of some kind of separate, and I have at least not had a patient, but I have seen a couple of my colleagues have dealt with this with Johnson & Johnson with PE in 2 patients. Again, mostly it's happening between 4 to 30 days is what I've heard. And thrombocytopenia is almost always there, though thrombosis may or may not be there. And usually it's kind of severe, between 10 to 100,000 is what I'm hearing. It's not a mild thrombocytopenia. So it is enough to kind of, take notice of. So mostly I think the recommendation is that, you have a history of vaccine within the last 2 to 3 weeks. You have developed some headache or, some abdominal pain. So it's either cerebral vein sinus thrombosis or mesenteric, somehow unusual site thrombosis. So accordingly, nausea, vomiting, abdominal pain, those symptoms, you suspect it, do a CBC, see if there's a low platelet. And if there is a low platelet, then you go ahead and image it. And I think the just a CT will not show. You have to either have a CT venogram or MR venogram if your center has that. Or depending on if it's a mesenteric vein, then an MR abdomen, and identify that. And if there is, then I think the other thing would be to, for the testing part, I think it's complicated. In our place, this is so new. We have not seen a lot. Majority have had Pfizer or Moderna. Only few patients have had, Johnson & Johnson. There is, we don't at least have in our center, but the heparin PF4 test, ELISA, is what is recommended. And this has is a sent out. I think we can do, at least we have not seen that much to test. So I don't think our center is really looking into this, but this is the same heparin PF4 test you're looking for. And the way you manage is you avoid heparin. I think that's the most important thing to remember, is you don't do any heparin, just like you would for the HIT thing. And then you either treat, the treatment recommendation is IVIG, because it's kind of like an autoimmune or some form of an antibody induced kind of thing. So you either do IVIG or you can do steroids, rituximab, or things like that. That's kind of the recommendation. I've had a colleague of mine had a couple of patients. I have really not had any patient who have seen this. And
thank you so much.
Yeah, but something ASH is also coming up with, I think, guidelines-wise.
Shravanti, there's an interesting question. Admitted patient on low molecular weight heparin develops hemorrhagic complications like hematuria. After some time, can we re-challenge again with the same or use different anticoagulant?
So, I mean, if you have a hemorrhagic complication like hematuria, if it's massive, just like anybody else who's bleeding, I would stop because you don't want them to bleed and die due to bleeding. So you would stop. Can we re-challenge again? Yes, if the hematuria stops. I would be concerned about using any kind of DOAC or warfarin, right? I would prefer using short acting, like some kind of a heparin based, even if I were to re-challenge them. And then look into what is causing the hemorrhagic complication.
Okay.
So, Dr. Kairam, can I use a couple seconds?
Of course.
So I wanted to comment about Prem Kumar's question. So we happen to see 1 out of the 6 patients who developed what we call now vaccine-induced thrombotic thrombocytopenia. And I actually was in service and actually failed to recognize it. And 3-4 days later, when patients started developing dural sinus thrombosis, we started looking into it. So the PF4 antibodies in this particular condition could be negative. So we typically just go by clinical symptoms of anybody after 10 to 20 days after somebody has received an adenoviral vector vaccine like J&J or AstraZeneca. If they present with headache, some neurological signs, rapid drop in platelet count, and thrombosis in unusual sites like dural sinuses or mesenteric veins or things like that should alert you to that possibility. So in this patient, what we did was we gave IVIG up front, assuming that this was some kind of an autoimmune disease prompted by the vaccination, and then treat the patient with ergatroban, which is typically what we do for HIT. So it's similar to HIT, but it's not exactly HIT. And we actually used heparin, and the patient had bleeding from heparin and actually started clotting more after we started giving heparin. So this was actually reported by a group, I think it might have been published in New England Journal, but out of 6.8 million J&J vaccines, there were 6 cases reported. All of them were women between the age of 18 and 50. So now our J&J vaccine comes with a warning, beware in that age group, 18 to 50 women. In terms of this, it's still pretty rare. The risk-benefit ratio still is towards the vaccine, so we're not discouraging J&J, but just an alert. The similar clotting episodes were seen in Europe with AstraZeneca. And even in India now, I'm seeing patients, especially a few days, a week to 10 days after they received AstraZeneca. I've seen women in that age group, 18 to 50, come up with what looks like cerebral vasculitis, just a long segment stenosis for no reason, for somebody who has had no risk factors coming up with strokes. So that's something I think that we all need to be aware of, especially in women.
Right. And I think it would be interesting to, for somebody to actually look and see what kind of underlying, young women were predisposed, and that's kind of very typical even for cerebral sinus thrombosis. Outside of vaccination, young women usually are predisposed to cerebral sinus thrombosis. And again, there's been some link with OCPs and cerebral sinus. And I think it would be interesting to see, a paper which is looking at what other underlying factors could have predisposed, though, I'm sure the vaccine and the vector had, some kind of polyanionic charges similar to heparin causing these PF4 antibody complex formations. But I think that was, young woman is what it was reported, but interesting to see that. Any experience with this kind of thrombosis Covaxin? Unfortunately, I don't know much about Covaxin. I apologize for that. Can you please go ahead and share what kind of cases you have had? It would be interesting to know. And that's Shyam Prasad. We don't have any, at least not that I have heard of.
Yeah, this was just a couple of anecdotal family and friends noting a couple of patients after Covaxin. Patient collapsed and found to have a PE. Both cases. One was like around 60 years, and the other one was like I think similar, like 50 to 60 years, male. not a female patient, but it was after Covaxin. I think Dr. Prem Kumar or anybody in India who have seen any of those kind of cases post-vaccination, especially Covaxin. I know AstraZeneca, I heard about the AstraZeneca thing and the J&J, but we don't have any. I don't think, so I was looking up some safety data about Covaxin, and the only thing I could see was a phase 2 trial data that was like submitted earlier in the year, like maybe January or something. I don't see any safety data like phase 3 trial that was published, and the incidence of thrombosis and other things like that. So maybe people in India might be able to know.
Yeah, it would be interesting to know. I mean, for if there's any case reports of that. Again, not familiar with anything related to Covaxin.
Dr. Shamprasad, how long after the vaccine did she have this event?
One was 6 days, the other one was like 10 days.
And there was no other features of this reaction?
No, both of them were, they collapsed at home, they were taken to the hospital, and one passed away and the other one said that they had a PE. So, I mean, it's a very anecdotal, very random example. I don't want to, say those things. Yeah.
Until
but
more is known,
anybody.
Yeah. Until more is known, it might fall within the phase state, right?
Exactly.
Dr. Tigavarapu, I have a couple of questions. One of our regular doctors has a question. Dr. Ayappa, yes, here it is. Oh, I see. You may have answered this already. Among the different anticoagulants, which one is preferable? I think you answered that both for the prophylactic and therapeutic. Okay.
Yeah.
So then there is a more recent one with, one second. This is one of my problems. Between Covaxin and Covishield, which vaccine has encountered the escape mechanism of vaccine-induced immunity? Are there any studies?
Having not dealt with either of those, I'm so sorry. I will have to defer that question to Dr. Buddharaju to see if he's aware, because I've really, not dealt with Covaxin or Covishield. So I apologize for that.
Dr. Lee?
Yeah, so I think with the studies on monoclonal antibodies, when the FDA issued EUA, there was a clear-cut warning from FDA to look out for particular strains in your community. And I think there was some data to suggest that the EK484, I think, was a strain and was resistant to the monoclonal antibodies. So single point mutations in the new strains could potentially, bypass antibodies generated by vaccines. That's a concern, and that's why WHO and CDC have started labeling strains of concern when they see a new strain. So they're looking at the current Delta strain in India. So there's no reason to believe, at least from what I'm hearing from talking to CDC people, at least for now, about bypassing the vaccine. But I think it's only a matter of time. And that's why I think the FDA and CDC here have taken the direction of including the new strains and potentially starting with boosters. I think we're hoping for boosters in this country in December from both Moderna and Pfizer. I think that's going to be the fact of life. And down the road, we should expect some bypassing. There's some strains which against which we know that the vaccine, especially Pfizer, in a study in Israel, I think there was some, the results were not as good as the original Wuhan strain, if I remember right. So that's to be expected.
I think though we have had a couple, I mean, I think though recently, I think we have had a couple of studies at least showing that, I mean, I know those were mostly derived from infection-related immunity, you know, kind of lasting quite longer, but we may have some quiescent, you know, bone marrow plasma cells, you know, having some memory to infection and even probably extrapolating that to COVID vaccinations. I think we don't know. I mean, as you said, rightly, booster shot is probably what Pfizer and Moderna are likely going to, especially with them showing, I think, 6 months immunity so far.
Yeah, I think there was a publication from Emory about memory in the plasma cells that lasted well beyond 6 to 8 months, I think.
That's right. Yeah, yeah. There was, I think, when they did some bone marrow aspirates and looked at plasma cells, which was interesting, and hoping that we still have that quiescent lifelong population, which can, you know, have some memory, but only time will tell.
Dr. Srinivas has a question. What will you recommend as anticoagulant for rural practitioners dealing with many cases of COVID? You may have already addressed it, but we might want to repeat, please.
Again, if, I mean, I know Coumadin is probably the cheapest, but I think with all the monitoring and everything else, it may be tough. So again, heparin based is what I've been saying. If it is available, I'm sure it is cheaper than Dovax. It's probably not cheaper than the Coumadin or the warfarin, but heparin based formulations. It is, I think, in coming to that, it's encouraging to see some of the data from these randomized trials that prophylactic dose was enough, and really do not need therapeutic, which can make things more complicated, you know, at least initially. But again, I know the moderately ill is a population where you may need, but at least for the time being, we can assume until those final peer-reviewed results come out that prophylactic dose would be enough for these patients.
Thank you.
So I think Srinivas' question was about ambulatory patients. So to clarify his question, for ambulatory patients right now, there's no role for prophylactic anticoagulation. The current guidelines are for basically hospitalized patients. I think Srinivas is talking about outpatient management of rural patients.
I see. I take that back. Yes, exactly. Yes. There's no indication for any prophylaxis in ambulatory setup. I thought hospitalized patients in rural part of the town is what I was thinking. Yes, exactly.
Yeah, because I see a lot of community practitioners in India, especially in the rural side, because of, you know, scarcity of beds and healthcare resources, they're tending to start anticoagulation as outpatient itself. And the typical prescription that I see is 2.5 milligrams BID of apixaban. I keep insisting that there's no data to suggest that that's going to be of any benefit. That question is going to be answered, I think, by Tom Ortel's study from NIH.
Yeah. It would be interesting because I think the rate of microthrombosis in some of these autopsy and other specimens almost up to 91% from some of those autopsy studies. And one always wonders, you know, about why it didn't help in the severe state. And, you know, will some benefit be derived if you start ahead of time, given the fact that there's so much link up of mortality and all these microthrombi seen in the lungs in these patients.
Yeah, so there was an autopsy series early in March, April of 2020 from Louisiana that showed that pretty much all those autopsies showed a lot of microthrombi and even macrothrombi. So that prompted some of the New York clinicians to give therapeutic doses upfront, and in some cases even thrombolytics, only to realize that the mortality was actually higher, and that quickly stopped. And I think
that's true. We had a study from Houston as well. I think about 23 patients or so. Similar study, but you're right. I think, you know, that practice immediately started when there was not much benefit, which they saw. Yes.
Dr. Mallampalli has a comment related to a previous question. Shyam Prasad.
Yes, regarding vaccine effectiveness, WHO has been monitoring all these strains and has been doing studies on the different vaccinations. Until today, all of these, out of these, I have a thing I can read up from. So the B617, B1617, which is the India strain, they're saying that has the most transmissibility and has 2+, they marked it under with pluses, 2+ immune evasiveness. But it is proven to be still, the vaccine is still proven to be effective against it, especially they said effectiveness from real world evidence versus severe illness. Importantly, mRNA and AstraZeneca is effective, about 30% effective in that variant. But the B1351, which is the new name, is the beta variant. Immune evasiveness is much higher for that. The relative transmissibility is not sure, but rest of all the variants has good vaccine effectiveness.
Right. And again, I think with time, because I think again, as you were rightly pointing out earlier, I think we have to see if booster shot, can help with some of these. And again, just like our flu, where they're looking at these capsid antigens and other things, I don't know if they will try to modify the composition, the booster shot. I don't think I've heard of anything like that, but it would be interesting to see what Pfizer, Moderna, or Covaxin, Covidshield has to come up with.
WHO has good information on this. I would probably ask all of you to look at that, maybe monitor it closely, because again, it's only a matter of time that one of these variants will be not effective as much as until now. And that's another reason why vaccination should be, the speed of vaccination should be very fast, and hopefully India should achieve the level of vaccination that it needs before there is a new variant that is evading all the vaccines that are available.
Would you consider coming to Texas, please? I saw 110 patients in a new practice in the last 3 months. 65 of the mothers whose children I saw have not been vaccinated. They're not going to be vaccinated, and they don't believe in it. So, Shyam Prasad, why don't you come to Baytown, Texas? I have a question.
Actually, Texas has one of the highest rates of anti-vaxxers, I think 60 or 65%.
Right. I mean, there are so many patients in my clinic where they have no good rhyme or reason, will not vaccinate whatsoever. It's sad, but that's the truth.
So, picking up on where you were a moment ago, I don't know, we are digressing a little bit from anticoagulants, etc. The 2-dose mRNA vaccine in that context is better than 1-dose mRNA for the Delta variant. I don't know if I'm understanding it correctly. Sanjeeva, you could explain to us, if you had to give only 1 dose, if you had to give only 1 dose, 2 doses is better, but 2 doses is the recommendation, right, for the mRNA vaccine. Is there something different for the Delta variant? I did not understand the question. You might ask it yourself.
It is in the same paper which the previous or the panelist was mentioning. They said it's in the same paper. It's written that 2 doses are more effective for the same Delta variant, and there are breakthrough infections for the AstraZeneca vaccine for the Delta one.
I see.
Yes, Dr. Sanjeeva. Yeah, 2 doses are more effective.
All right, I won't let it go now. Interestingly, Dr. Patisapu in Orlando, Florida says, also half of our staff also declined the vaccine, including our MDs. We got trouble coming then. Very sad. Dr. Sarkar, the pulmonologist from Shimla, who's a recent arrival, Netherlands study by Clark et al. Showed 31% breakthrough thrombosis. All patients were on thromboprophylaxis. What are the reasons for breakthrough thrombosis despite prophylactic anticoagulation?
Yeah, that's a great question. Again, I have to actually, I've heard of this paper, but I've really not read all of it. And I think, a few things, what I remember, and again, I really have not looked at this paper in detail for reasons of breakthrough thrombosis, was the question, was again, what were the underlying risk factors? I mean, what was this, the cohort like of the patient population to begin with? And again, what was the severity? Was it across all groups, like moderately ill versus severely ill, kind of, or hospitalized versus ICU patients, and so on? I think that's something which needs to be looked at. So I really have to look into that, but I would suspect, I think those were some things which need to be, looked into for breakthrough thrombosis. I would mostly be interested in looking at the patient cohort. Dr. Buddharaju, I don't know if you are.
Yeah, I think Dr. Sarkar might be talking about a publication May 21st, I think, from Journal of Thrombosis and Thrombolysis.
Yeah.
I looked at it briefly not too long ago. I think, the data is no different from what we saw in US. Whether people had the thromboprophylaxis or not, at least 1/3 of patients who were in ICUs and in the hospitals had evidence of thrombosis on autopsies. I don't think this paper, showed anything different than that data. So yes, in spite of thromboprophylaxis, autopsies consistently show evidence of thrombosis, at least in 1/3 of people, or even more sometimes. The Louisiana autopsy series, I think more than 50% had the thrombosis, macrovessel thrombosis, I think. Yeah, and the surprising thing is, in spite of so much of evidence of thrombosis, we're still not sure why it's not translating into a survival benefit in patients with severe illness who are getting therapeutic doses. So that's still a mystery. So I don't know if it's related to increasing bleeding incidence in these patients because of endothelial injury and alveolar injury, or it's a function of something else.
Yeah, I think if you look at, even those RCTs or other studies which I quoted before, definitely the therapeutic dose anticoagulation reduced the thrombotic events. It just did not translate into a survival benefit or a mortality benefit or an organ support 3 days. So, so I think there was definitely, I mean, as Dr. Buddharaju said, despite all the Lovinox we did, we kept seeing clots, and of course microthrombosis was happening, and that's why these patients were dying, or some of these patients were at least dying or succumbing to that. But therapeutic anticoagulation, even in the severe arm, did show that there was a reduction. I have not put the data, but there was a reduction in the thrombotic events. It's just that it did not translate into a reduction in the mortality or survival benefit or organ support 3 days.
Dr. Sarkar continues, is there any role of heparin resistance? I don't know whether it's in that case or in general.
I have not come across anything. In fact, we have encountered patients with heparin hit patients, where we were, as earlier was pointed out, we did argatroban, bivalirudin, and things like that. Just how we would treat HIT, but I have not come across any heparin resistance, at least not that I have seen.
So the DIC we see with the severe COVID is different than what we see with non-COVID DIC patients in ICU. For some reason, these patients, don't bleed, but clot a lot. There's thrombosis all over the place.
Yeah.
So it's a different disease altogether. If you notice, the fibrinogen levels are always elevated in these patients, unlike what you see in case. Yeah. So the other question about D-dimers is, as per American Society of Hematology guidelines, we're generally not basing our therapeutic decisions based on D-dimer levels. At least that's what we've been doing out in Midwest. I don't know if Dr. Tigwarpu is doing it differently.
No, I think very similar. I think we were checking. We were probably even monitoring, but we really did not make any changes to practice. That as the D-dimer went up, we at least again, I don't know if in intensive care, they were trying to modify certain things, but at least when we were consulted on these patients, we did not make any changes based on D-dimer. Though I think they've had late studies, I think some of the bigger ones from Wuhan, where they had some D-dimer cutoff values of over 2, and again, or higher, being pretty prognostic for judging, bad outcomes and death and things like that.
Maybe Dr. Chilamuri or Dr. Guntupalli can answer that. Are they basing any decisions based on extremely elevated D-dimer levels in the ICUs?
In the early part of the epidemic, we used to use that. High D-dimer was an indication.
We were also measuring.
But of late, we stopped doing it. We haven't seen it. Go ahead, Dr. Guntupalli.
I mean, I have to say, I don't have the actual numbers. I must say that initially in the first and second surges, that is between March and August of last year, we did see almost a third of patients to have even PE when they came into the ICU. And I didn't want to say it, but we have some patients who were on therapeutic anticoagulation because of high D-dimers and suddenly crashed, and D-dimer went very high that day, ended up dying, full anticoagulation, heart, lungs, everywhere full of solid clots. So I don't know, there must be some phenotype or some sort of extremes that some people are reacting this way. I must say that last 1 or 2 months and this week, I'm in the ICU, I'm not seeing as much of, like we used to see the PEs. Like if almost a third of patients I would have PE in the ICU with COVID. Now I'm not seeing as much. Maybe we are being more aggressive on the floors before because they generally not a direct admit, they may crash on the floors and come. So we are not seeing as much for whatever reasons. Maybe we are hydrating them better, whatever the reasons are. But are we measuring?
We use D-dimer in 3 different.
No, we were measuring in the beginning, and even now, I think we'll measure one time and maybe on day 4, but we are not routinely measuring every so many, like twice a week or something, unless they are in some sort of a study that requires it.
So Prem Kumar, in India, in Andhra.
So let me just finish what I was saying.
Sure.
And so the D-dimers, we use it 3 different ways. One is we use it to prognosticate. We actually publish that a D-dimer of more than 1,000 is predictive of poor outcomes at the time of admission. Especially if you do it 48 hours after admission, if you see D-dimers of greater than 1,000, these are admitted patients, they predict poor outcomes. So that's one way to use it. So that'll guide us when to discharge and not discharge, or when to move them to step-down units or otherwise. The second thing is, if somebody's D-dimers are high or rising, that'll prompt us to search for a pulmonary embolism or a DVT or something like that, but certainly push us to go search for it. Earlier you mentioned about lupus anticoagulant. In COVID patients who have a proven clot, 30% of them in our series had lupus anticoagulant. These are patients not suspected, but actually have a big clot. Lupus anticoagulant is fairly common in them. So that would be the reason why I'm searching for a clot if their D-dimers are high. We no longer using D-dimers to treat patients. We used to give anticoagulants, at least therapeutic levels, if the D-dimers are rising or greater than 1,000. We stopped doing that based on, I think there are 2 papers out showing that it doesn't guide you in terms of, because the outcomes didn't change whether you give therapeutic or a higher dose or even prophylactic dose, the outcomes didn't change. So we stopped doing that. So we don't use D-dimers to determine what anticoagulants and how much to give.
Are you measuring routinely, like on a regular basis?
Yeah, we do routinely measure them because we want to prognosticate. So we're standing by our data that it predicts outcomes. So
But is it like admission day 4? And suppose, I mean, we have people who are there for a month. So what is your routine to?
Yeah. So in people whose levels are continuing to rise, they tend to actually die. I don't know any of them who's reached 10,000, 20,000 D-dimers who've survived. They've all died. So after you've given your full doses of whatever steroids, remdesivir, and if you choose to give tocilizumab, and you still see D-dimers rising, almost 100% of them died. None of them survived for us. So we would know by then the D-dimers are not coming down. I think we kind of lost that game on those patients. So we're trying to look for salvage operations at that point.
So in India,
that's the reason why we died. Pardon me?
So in India, the ground situation, especially in the smaller towns, is slightly different. They don't have access to so they don't have access to imaging. So in smaller towns, you know, I've seen clinicians using D-dimers as a surrogate, and the moment they see the D-dimer rising or above a certain value, usually about 1,000 or so, they're very quick in initiating therapeutic doses of anticoagulation. So I wanted to find out from Prem Kumar if that's kind of become a routine practice there, or because here I'm hearing across the board in ICUs that, you know, they don't do D-dimers as often these days, and also the D-dimer is not guiding in terms of starting or not starting anticoagulation.
One of the things that you are not paying attention to is the fall rate post-COVID is very high. People who've recovered from moderate to severe COVID fall very frequently. And so if you give them anticoagulants unnecessarily, we had fair number of subdurals and intracerebral bleeds after they fell from COVID. In fact, that's a syndrome that we describe now as a post-COVID syndrome, is an increased rate of fall. So if you're giving it to, 60-year-olds and 70-year-olds, so you should clearly make a good, because they lose enormous amount of weight after moderate illness, their muscle mass is gone. So they are frequently falling. So you must evaluate them before you commit to anticoagulants of any kind. I mean, of course, if you have a proven clot, that's a different issue. But if you're trying to treat D-dimers and things like that without any evidence of a clot, you really have to balance the risk of fall before you give anticoagulant. A fall would be quite dangerous for them. They bleed quite significant in their brain.
So you may have indirectly.
Thanks for pointing out about, looking, which I forgot to mention is, I think first thing would be to look for clots, go ahead and look for thrombosis, once you start seeing a rising D-dimer. And that's what we typically did, and again, if we found a clot, we definitely would escalate the anticoagulation to therapeutic. If not, I think as you all discussed, we at least have not done any practice changes to anticoagulation just with D-dimer.
Yeah, that's what we're doing.
So the answer to everybody is, do not let D-dimer values guide your decision on anticoagulation.
So that takes you to the last question on the chat box. Dr. Kurmanad is asking, a very high D-dimer value touching 10,000 nanograms, not improving with therapeutic dose of enoxaparin, can we shift to IV heparin infusion?
I think this is pretty much what you touched on, I think, it's about like, have you already lost the battle by then? We don't know. It's again looking to see, yes, you could switch to IV heparin, but has the damage already happened that it will not make a difference? Maybe, but it's also looking to see, could you use other agents? Have you covered everything like Dex, remdesivir, tocilizumab, monoclonal antibody if it's available? I know, probably not, whatever is available there. It's, I think, again, like putting everything together you have on the plate and trying to see if you can make a difference. But probably patients like this really, unfortunately, may not make it, is what it sounds like. Again, it would be interesting to see, if you have any data coming on, if something new can, change things with this. But yeah.
Yeah, at 10,000, if that's rising 10,000 or 30,000, come down to 10,000. 10,000 is bad news. I think anticoagulation is not your problem at this point. If it's later in the disease, like third, fourth week, I would seriously look to see if he has secondary infection, bacterial, fungal, whatever. And this is actually sepsis syndrome that he's dealing with. Anticoagulation is not of concern at that point. 10,000, 20,000, that's not an anticoagulation issue. This is a sepsis issue that we have to manage it. But.
Well, with that answer, not making Dr. Kurmanath any better for tonight, Dr. Thigavarapu, I want to thank you very much for the way you have done this conference, because in the last few days, we had many questions asked on anticoagulation, when to start, when to stop, how to do it. Thank you very much for the time you spent. And Dr. Guntupalli, thank you for finding her. And Dr. Buddharazu for hanging in there. And Dr. Chilimuri and Dr. Mallampalli for your comments. Dr. Sudhakar, are you happy tonight?
Yeah, absolutely.
I would like to thank everybody, especially Dr. Guntupalli and Dr. Kairam for giving me this opportunity. Again, as I said in the beginning, I'm not a thrombosis expert. My field of interest is heme malignancies, especially lymphomas, but I hope I was able to answer some of your questions. And if I did not, I apologize for that. But I'm hoping this wave in India goes down and, we can see more people vaccinated and hopefully people in India come out of this wave soon. And I'm very optimistic about this because this is where we were last year and I'm sure India can do a better job.
We may call you back because it looks like several doctors in India have not been reading, don't listen to guidelines. They're doing some very, very improper things. So who knows? 3 weeks from now, I might call you back to talk to the crowd again. Thank you very much, Dr. Guntupalli, and also good night to everybody. So we'll see you all tomorrow night, same time.
Thank you. Thank you very much.
Thank you all.
Sudhakar?
Yeah. Thank you.
Thank you.
Bye-bye. Good night, everybody.